All right, here we go. 3, 2, 1. Hey guys, welcome back to the Foam Frat podcast. Tyler and Sam. Sam put out a very sweet blog on glucose this week, and I read through it, and I did not think you were going to possibly be able to make a blog that long about glucose, but you did, and you kept my attention with it. So good job with that.
Was it the mention of you somewhere in the middle that made you keep reading until the end?
Yeah, it was. It was the gigantic bottle of Mrs. Buttersworth pancake syrup and me standing by a longboard, which you have to know the history of that story for that to make any sense at all. But I believe it was it Ginger Locke's podcast? I think it's the first one I mentioned. Maybe not.
Maybe.
I thought it was. I asked my mom, and this is a question you guys should ask, like your friends, and just see what they say. You get some really entertaining answers. But I said, Mom, right now, if I passed out, let's just say all of a sudden Tyler just boom hits the ground, he passes out. What would you do? And she, without any hesitation, was like, I would go to the pantry and I would grab out some Aunt Jemima pancake syrup, and I would insert it into your rectum and pump glucose into your rectum so it would absorb very fast. So she just really just hanging her hat on the hypoglycemia card. And I was like, oh my God, that is terrifying right now. Like, what if I passed out from some other reason and I wake up and I have a pancake syrup in my butt? And so everybody thought that was real funny. And then there was even like Allie and Mike Herman from In Low Life Flight. I think that's the name of it. In Low is the flight program's name out in California. They came to fast with like pictures of like Aunt Jemima on their shirt and like me on the back. It was hilarious.
That's what made me remember that so well when I was thinking about, because there was a section in there about like home care and stuff like that, or not home care, but you know what I mean. You know, just short of giving somebody an actual dextrose solution, like what should you do in order to sign them off? And it made me think of that. So, but before we get into too much of like the clinical stuff about the blog, a couple of announcements. So you have tell us about the Philips conference first, or webinar.
Yeah, the webinar. So I've been doing these point of care ultrasound webinars for Philips Lumify. October 14th, we're going to do one on how you can use point of care ultrasound in the pre-hospital realm in addition with your 12 lead. So together to try to increase the sensitivity and specificity of acute MIs. And so we're going to talk about the views, what you're looking for. I think this is going to be probably one of the most popular ones just because there's so many questions on cardiac ultrasound. Mm-hmm. And if you look at how many MIs actually present with ST elevation, it's not that many. So can we use ultrasound to try to increase our accuracy? So it's October 14th. We'll put a link to that in the show notes. And it's absolutely free. So if you don't come, that's just ridiculous.
So that's awesome. So we'll put a link down in the description. Go ahead and register for that. Tyler does an awesome job on those, and it's cool to see him present on a different platform sometimes too. It's kind of a little bit of a different style, so definitely register for that. And the other thing is too, our friends over at the Recess Tailor, who have been featured on the podcast previously, we have a little giveaway going on. So during this video at some point, so you guys have to actually watch the YouTube video and look at our ugly mugs during the podcast. If you're going to win, we're going to have a little secret code that's going to pop up. And that enters you to win one of these guys, which if you're listening to audio right now, what I'm holding up is a Scram Bag RX, Tactical RX. And this is the really cool one. If you guys haven't seen these Scram Bags, these are super cool. These are the ones that have like the spots for the drugs inside. So like a spot for paralytics and pressors and whatever your sedative induction agent is and stuff like that. And so enter for a chance to win one of those, and there'll be a link in the description of where to enter that code as well. So I just wanted to mention that stuff before we get started. I can't mention the code at the end because then you'll have to go back and, and watch for it. But yeah, so speaking about these hyper and hypoglycemic patients, we talked about the Aunt Jemima thing. But there's things just short of that for you.
Yes, we did.
So Let's start this off. You get a diabetic patient, and we'll talk about how to reverse those. What I think is the safest way to reverse those patients if you do actually have to give them dextrose. But let's say that you just have a hypoglycemic patient and you're ready to sign them off. What's your threshold for signing off a diabetic? Because I think that comes up pretty often. There's a lot of programs out there who are like, there's people on both sides of the spectrum like, well, what if their medication lasts too long and they pass out after you leave, or stuff like that. Or there's programs that are like, why in the world would you ever transport somebody you reverse from hypoglycemia that's diabetic? Like, you should never transport those patients. What's your threshold that you're going to say, okay, I'm comfortable signing this patient off?
Yeah, it's so totally different on the helicopter because I never see those types of patients anymore. But on the ambulance, you see them all the time. And typically, the people pretty well. You've been there multiple times. And if it was just an accident where they slipped up and took their insulin and then they didn't eat their meal, you get there, you wake them up, make them a peanut butter and jelly sandwich, sit there for a little bit, let their sugars kind of normalize. And then there's absolutely no reason, I believe, to transport that patient. But if it's somebody I don't know very well, or the situation just doesn't make sense, I want to know what caused this disruption in their routine, right? I mean, they're not typically just unresponsive. So what caused this disruption? Did they get sick? What happened? And those patients you spend a little bit more time with, and you want to try to figure out, well, maybe they do need to get something adjusted. Maybe they need to get some meds adjusted. So that's kind of how I approached it. If it was one that was routine, and we did the same thing, made them a sandwich, sat around with them for a little bit, gave them some of those polysaccharide sugars that'll take a little bit to break down. And then I think that makes sense to do that. But I don't think you need to transport every single one to the hospital by any means. No,
I totally agree. I'm glad you brought up the sandwich. So that's kind of like a thing that people talk about, like, oh, you got to give them a sandwich and do this and do that. But there's actually some science behind what you give them to eat. So let's say you do have to reverse somebody, and maybe you give them glucagon. We'll talk about that, or some type of dextrose solution or what have you. The recommendation right now is that you monitor them for around about maybe 20 minutes after they're with it, because like you were saying, like maybe something's off with medications or something. The insulin can last quite a long time in their system. If it was insulin, or maybe it was glucophage or whatever, can last a little bit. And so the medications that we give, the dextrose and stuff, or oral glucose or whatever, I talk about in the blog a little bit that they're monosaccharides, and so this like sugars with no chains in between them. And like a disaccharide is 2, so it has like 1 chain. And a polysaccharide could be really long, where it's got a bunch of chains in between these sugars. And the longer that sugar chain is, the longer it takes to break down. And so usually it kind of sustains you for a little bit longer. And so with like really simple sugars, so you put a spoonful of sugar in your mouth, monosaccharides, like super quick glucose spike. But if I ate something like a really hearty whole grain bread or something, like that would break down much more slowly. It would I wouldn't hit these spikes and lows and stuff like that. And so the kind of the recommendation right now, monitor for about 20 minutes, and like you said, they need like a sandwich or something, because that's going to have fast acting sugar in it, like a monosaccharide, like white bread, jelly. But then you also can get them some fat and some protein as well, which is super important because it actually slows the breakdown of that glucose as well, and that can keep them sustained like really steadily. And so mixing, like, I hate the word like balanced diet, but they need like some short sugars, some long sugars, and then if you can mix some fat and protein in there as well, that should keep them sustained and keep them on an even keel for a while. So I guess let's rewind a little bit and go back to when we actually had to reverse this patient. So I want to go to kind of the basic level. So I talked a little bit in the blog about like the glucagon and the insulin being like counter-regulatory hormones, and that meme with, I'm a pancreas, and like we kind of play pancreas where we have the glucagon on one hand and the insulin on the other, and we really are like playing pancreas in the system in the absence of a working one. What were you taught? So when you were in school, you first start learning about glucagon. Did they tell you it was going to work right away? Because they told us like this was a magic bullet for these patients where they was wake up right away.
Yeah. So glucagon was like our plan B. Mm-hmm. And The plan A was obviously to get an IV, and you're never more stressed out than when you're trying to get an IV on a patient with a glucose of 20, because I can fix this really quick if I could just get this IV. And unfortunately, diabetics don't make the best for vasculature and easy sticks, so it's not always an easy IV. So if you couldn't get the IV, then you could give them some glucagon, and then that would kick in right away, right? You just push the glucagon, and boom, they wake up, and all is good. And it doesn't happen like that at all, right? There's a whole process of things that have to occur. And usually by that point that you're pushing the glucagon, you're like already wasted a couple IV attempts.
Yeah.
You're a little bit into it. So I don't know, maybe if you think they're going to be a tough stick, you do it early. But even if you do it, like, you're still not guaranteed that it's going to do anything. It's completely dependent on how they store that glycogen.
Yeah, totally. So yeah, if they have glycogen stores, then it should work. So I'll tell you what my experience was with it. So like going back all the way to EMT school, I remember this was like our first big, like, serious medication, I think that we learned about. We learned about diabetics, and then we learned about glucagon and this different kind of stuff. And our teacher let us actually give her an intramuscular injection, which was super exciting for us because we had never, this was like real, medical stuff that was occurring now. Like, we have like needles and syringes out, and we have this patient who's, comatose or whatever. And so she's slumped up against the wall playing the patient. And, we had practice on the little injection pads. And so we were like fresh on this, and we're like, I remember being nervous to put a needle in. And I'm like, all right, we're really doing this. And so, we practiced the skill of taking the blood glucose, and then it, reads normal, obviously. And then she's like, okay, so imagine that says, low, or, 25 or something. And we're like, okay. So then they're like, what are you going to do? We're going to get this glucagon out, and we're going to give you a milligram of it. And so she let us, she pretends to be unresponsive, and we put it in her deltoid, and we hit the glucagon, and 5 seconds later she pretends to be up and at 'em, and I remember thinking, I've got
Like bringing out the dead
keys.
style.
Yeah, I've got the keys to the diabetic kingdom right now. I'm like, I'm ready to go out. Give me these diabetic patient calls, and this is going to work. And then I brought out in the blog, like, it can take up to 15 minutes to work. So, maybe that's something that is a plan A. I don't know, is where it's like, do you give it right away and then focus on starting your IV? Or maybe if you have two people, you're giving it right away, and then also going for the going for the dextrose. I guess it kind of depends how you approach that situation. But yeah, it takes way longer than some people think. And so if you are planning on using it, or if that's part of your game plan, you might want to do that a little sooner rather than later, because if you wait until you've missed 3 IVs and then all of a sudden you're like, all right, well, let's see if this glucagon works. It's like, what are you going to do? Sit around on your hands until for 15 minutes for it to kick in, and then maybe it kicked in.
I've heard stories of people it not working and them doing an IO, and you can imagine, like, the patient wakes up and they have a drill, this big needle in their arm or in their leg, like, kind of like you have to go to the hospital at that point. Like, I don't think you're going to try to pull that thing out and then sign them off.
Yeah,
But
that's something that I
know.
don't know. I've never thought about signing off a person that has an IO. I don't know if you can do that.
Can you imagine?
I don't know. Like, I've never even thought about that in my head before. I'm sure somebody in the comments will let us know what the procedure is if you ever have to do that. But yeah, so you don't want to have to go down that road, right? So let's fast forward a little bit. So you got this hypoglycemic patient. Let's say we gave him the glucagon. We already know our post revival plan. We got to get him a sandwich, different, macronutrients and stuff. So we give the glucagon. We know it's not going to work for a little bit. We know what that glucagon does. If they have glycogen stores, it's supposed to go over to the liver, breaks down, or that glucagon goes to the liver, breaks down glycogen stores. Glycogen's a really long chain, so polysaccharide. It's like 24 carbons. Glucose is like 6, so it's almost like 4 glucoses like stacked on end, and it goes in there, cuts them up, and then all of a sudden they have blood glucose. Maybe if they have stores, right? So I put out this supposed method for reversing the hypoglycemic patient that I think is maybe the safest. I thought about this for quite a while, and I was like, how can you avoid extravasation in the patient that has hypoglycemia? Because that's the big thing. Like, and that's why you're so picky about your IVs, and you start at the hand and then work your way up. Because it's like, man, if I make a hole in the AC and I don't get it, it's like, is that, if I put it in their hand, then is that going to leak out upstream? Because that could be a huge problem. That's not just, regular old, it's not going to melt their adipose tissue. There could be a nerve in there. It could, get at an artery. Who knows what could go wrong. It could be actually really dangerous. So you want to make sure your IV is really good. And so what I set out in the blog was that what I think is the safest way to do this is just to start an IV. It doesn't have to be a crazy IV, because you're not going to push this D50 straight through it. That's like too old school. Like, it's kind of dangerous in my opinion, and I think a lot of people's opinion. And so what you do is you just start an IV, and then you hang a 250 bag just of normal saline. So 250 milliliters of just normal saline. And what you do is you infuse like 50 mLs. And that doesn't take very long. And maybe even not 50, somewhere close to 50. Check the arm super good. Make sure that it's not like going around. I'm sure you've seen like those not false passages, but you kind of get in between layers of tissue, and you're on the top of the arm, and then it goes around to the back of the arm somehow, and you got this cold pocket back there, and you're like, oof, man, I'm glad I didn't put anything else through that. So that can happen. So I think maybe like 50 or so mLs. And then what you do is just take your D50 and squirt it into the bag itself. And that essentially makes D10. The glucose to fluid ratio is the same, except you have some sodium and chloride in there, obviously, as well. So after the dextrose is gone and metabolized, let's have an isotonic fluid. And I think that's the safest way. The recommendation right now is for every 100 mLs, you reassess the adult at every 100 mLs. And then for pediatrics, you do every 2 mLs per kg. And so that way you don't like overshoot them. So, I mean, I posted it into the blog to ask anybody if they could think of a safer way to do that. Can you think of anything that could be safer about that?
No, so just say that again. So you, for 100 milligrams per deciliter of, that's how fast you want to bring up their sugar? Is that what you were saying?
It's just the fluid. So they only measure it in volume because it's like a fixed concentration. So like if it makes a D10, then for the adult, you would infuse in 100 milliliters. Oh, and then reassess them. So that would be like their dose. So if you got 250 in the bag still, because you put another 50 in with the amp, you essentially have like 2.5 doses in there. So you'd run in 100 and like, okay, where are we at? Okay, so sugar still sucks. Put in another 100, and then you probably won't need more than that, because who needs more than an amp of D50 typically? But then with kids, it'd be 2 milliliters per kilogram. So because it's that fixed concentration, you're only really worried about the volume. So you're measuring your dose and volume.
Yeah, I almost wonder if D50 is even necessary. Like, you probably could get away with going even lower on that, because you don't need all of that dextrose. And I know some programs will carry D10 and maybe a bag of D5. I'd be interested to see if you hooked up a bag of D5, how long it would take for somebody's blood sugar to come up. Probably take a little bit longer than you want. You'd have to give more volume. But I think that method, I mean, you're giving 25 grams, 250, you got D10, and running that in, and then when they start to wake up, maybe you titrate it down a little bit, still keep it running just a little bit, and then evaluate their glucose. I love that method. I think it's probably one of the safest methods out there. I remember my paramedic instructor used to tell us, when you're going to push D50, you take your bag and you drop it on the ground, and you see if blood starts to come back up the line. And if it comes back up the line, then you know you're good. And so I've done that a couple times. I've taken the bag and like dropped it lower than the patient. Mm-hmm. And if you start seeing blood come up, obviously you don't let it pink out the bag, but you would know that you have a good line at that point, where if it doesn't, it's like, okay, why is that happening? So I don't know if there's any reason to not do that, or if that's just something, a cool trick. But as soon as you were saying that, it made me think of that.
I never heard of that before, but I like that idea. It's kind of like hooking up your syringe and seeing if you get any return into the syringe. But I suppose like with a syringe, you're pulling back on it. But with that, you're just kind of letting gravity. You're kind of seeing if that vein is patent enough to overcome the weight of the fluid in that is if it's pretty equal, like as long as it's not like creating a vacuum and pulling it back the other way. No, I think that's pretty cool. I've never heard of that before, but yeah, I think that would definitely tell you if you had a good line or not.
Yeah, because even if it's in a vein, if it's a real fragile vein or a small vein and it spasms or it kind of clamps down, you're not going to get a good return. I mean, we've all had IVs that you can flush, but you can't pull anything back on. And I wouldn't feel comfortable pushing D50 through something like that, or any D25.
Do you think that there's and this is like totally off the cuff, I didn't like really think about this or address it in the blog. Do you think that if you're giving fluid or dextrose in that manner, so let's say that you do the method that I prescribed where you're infusing the saline first and then you're hooking up D10 to it, you're essentially making D10 afterwards. Do you think that there's a minimum size of IV you would need in that circumstance? Let's say for an adult patient. I mean, you're running in D10. Do you think it's not like you're pressure bagging in or slamming a thick bag or a thick amp of D50, you know? I wouldn't think that there's a minimum size you need for that.
No, I agree. I think you'd probably be fine if with a, I don't know. I mean, if you're using a 22 in the hand for a brittle diabetic, as long as it's diluted out, I mean, you can do that, you know? So I don't think that would be an issue. We, at LifeLink 3, we carry hypertonics, so 3%. And so I've done that with the bag a couple times just to make sure that it's good before you run it in, because you're running hypertonic at 600 mLs an hour because you give 150 over like 15 minutes or so. So you're giving it pretty quick. So if it was going to extravasate, it would like pretty quick.
Yeah. Yeah, and I think that's another win. So first of all, you know, just using D10 in general, because a bag, for those of you who are like not too familiar with the dextrose solutions, the bag of D50, I'm sorry, don't do a bag of D50. So like a bag of D10 is the same amount of grams. It's the 250 milliliters of D10 is the same amount of grams as an amp of D50. So if you've infused a bag of D10, you've given the same amount as an amp of D50. It's just, it's diluted, 5 times. So that's definitely safer. And then checking your IV like crazy. I put some pictures in the blogs of some extravasation from glucose, and it's no joke. I mean, people, you can legit lose a limb from that. So that's one of those things that we get away with like a lot of the times. Like that's one of those things that's not best practice, but we get away with it a ton, is like slamming D50 into a line, and you do it 50 times and it's all good, and then on the 51st time it extravasates a little bit and you kill somebody's nerve or something. That would feel like crap. So
it's a jerk move. That's
a super jerk. The more I learn about extravasation and cutting people's limbs off, I just think it's a real jerk move.
You know what I was thinking is you talking about running in a little bit of fluid before you like push the dextrose in. If you ran exactly 50 mLs, like then when you add in the 50 mLs, then you would be 250, and then you'd have 25 grams of dextrose, and so you'd be like the same concentration, right? Am I doing that right in my head?
No, totally. That's what I was getting at this whole time, man. It's D10.
Well, yeah, but you said just run in some fluid, but if you ran in exactly 50 mLs, whatever.
You're smelling what I'm stepping in, man. I like that. I like that a lot. Yeah, that makes that makes D10 right there. And
I'm just thinking about this.
Is 50 mLs. So you waste that sucker into the patient. So 50 mLs go in.
Yeah, but you didn't say that. You didn't say waste 50 mLs. You just said just let it run for a little while.
Yeah. Put waste 50 into the patient, I guess.
So that part was my idea. So if you name this method something, you got to add in the
the blog already published, so I think I got dibs on this one.
Well, I'm in the editor right now. All right, so we're going to talk about hyperglycemia too, or do you just want to keep talking about hypoglycemia?
One other thing, just with we can talk about hyperglycemia a little bit, but just one more thing with the hypoglycemia is I found out that you can have brain hypoglycemia, and I was blowing you and Brian up with these text messages because I thought it was so cool. You can have brain, so they call it neuroglycopenia, which is a low blood sugar in the brain without having a low serum blood glucose, which I thought was really crazy. So I was doing some research into that, and salicylate poisoning, I guess, makes your neurometabolism like crazy, and so it eats up sugar, and it goes hypoglycemic like around the cerebral circulation, but the blood glucose is normal. And so I thought that was really crazy. Neurological symptoms of hypoglycemia, but you check their blood sugar and it's normal. And so it's standard practice now to keep their blood sugar really high. I don't know what that limit is, but empirical dextrose is given to those patients with salicylate poisoning because it's a known thing. And once they get hypoglycemia.
Is that a demand hypoglycemia? Like the brain is demanding so much, it just can't provide
I believe
it?
so. But there are other ones too. So you can have low glucose in the CSF I was reading about. And there's a bunch of different kinds of meningitis that can do it. And then also certain infections as well. If there's a lot of leukocytes in the CSF. And then what was the other one? Bacterial and fungal infections. If you have like a CSF infection, that infection has gotten into there, what happens is the glucose comes in from the blood. So it's like one layer is blood. Next layer down is CSF. Next layer down is brain tissue. And so what happens is that stuff that's sitting in the CSF eats up that glucose, like bacteria, fungus, whatever, eats up the glucose, and then it never gets down to the brain. And so they also get neuroglycopenia. And so that's something we would never be able to diagnose, but it's something that I found that was really cool. I guess the salicylate poisoning, I mean, that's empirical, so you could do that, but I don't think we're going to measure any CSF glucoses, which I found out is supposed to be 2/3 of your serum glucose.
Yeah, dude. So do you remember like learning about taking like the halo, like when people are bleeding from their ear and checking the glucose of that? And I always heard it was half, that it was whatever the CSF glucose was half of what the serum glucose was. So if you'd like check the sugar in the finger and it was 100, and then you check the sugar up here in the, like if you think it's CSF fluid and it's 50, that is CSF fluid. And you could check like that halo sign and then check a glucose out of that. So that makes sense. I was thinking about that when you were saying that. I don't know what the benefit of that is, but it's one of those little. See, I got all these little fun factoids for this episode.
Yeah, yeah, I'm liking these. I'm liking these a lot, and I love your method with the D10 and D50. That's genius.
Well, you know what? You should listen to me once in a while.
Yeah, I'll definitely start, man. All right, so let's. So here's something with hyperglycemia. So I don't want to cover like the DKA, HHS type stuff because I think we've done quite a few. We did a couple episodes on that more recently.
Yeah.
We did that Don't Stop the Insulin one. And then we have a couple blogs on that as well. So I don't want to go into that, but I do want to talk about one logistical thing, which is what to do if you transfer somebody. So this isn't really a pre-hospital thing, but what to do if you transfer somebody who's really hyperglycemic and you can't monitor the glucose because of how high it is. So like, you guys have point of care. So what does your glucose go up to for point of care? So you do a finger stick on somebody or a draw. How high can you guys read?
I want to say they're both 600. So we don't really get much more out of the epoch, if I can remember it. If you guys know that, correct me. I tried to find the answer to that. But yeah, I believe it's 600. So if we go in and somebody's sugar was up in the thousands and they're an hour into it and now it's at 900 or so. It's really all about that trend. If you see that trend going really quick, then yeah, you want to turn it down a little bit. The fear is that the serum Oz is so high because they have all this glucose in there, and it starts to pool in fluid from the interstitium. And then if you reverse that and you get rid of that glucose, now you have all this fluid inside the vasculature, which is why diabetics, DKA patients pee a lot because they have all this fluid in. But if you shift it too fast, all that fluid's got to go somewhere. And the spot in the body that's most tightly regulated is the ICP and the brain, the Monroe-Kelly doctrine. There's just enough room for the brain, the blood, CSF. And so if you shift that too quick, you can cause cerebral edema. As you get older, it's not it's not as common. You're going to find that if you look at the literature, it's mostly pediatric literature because, as you've mentioned before, like you get atrophy when you start to get older, your brain starts to shrink, which is why you're at risk for bleeds that don't show up for, you know, a long time in some of the bridging veins and stuff, because there's space up there. So that's kind of my approach to it. If it's an adult, it's like, okay, we'll watch it. Obviously, you got to transport them. You're not going to be like, well, we can't transport them because we can't monitor it. Look at the trends and see how it's been. And if everything's looking fine and you're, you know, you keep in mind like your potassium, if you're shifting insulin, you're shifting potassium, keeping all those things in check, then usually it's not an issue.
Yeah. I think there's a little bit of a difference maybe with HHS and DKA. I don't know. I mean, the fear is like, yeah, maybe you don't have a trend. And so if we don't have a trend, then, you know, we can only see it once it comes down to 600, or maybe your glucose monitor does 500 or whatever. So I'm not going to know how fast they go from, 900 to 500. And what if it's really fast and my glucometer is just reading, you know, high the whole time. But honestly, with a DKA patient, you know, we've gone over this in other podcasts. Lowering the glucose is great and all, but running insulin is like, that's where the money is, you know? So if you have a DKA patient, first of all, they're not going to probably be as dehydrated as an HHS patient. Their glucose probably won't be as high in the first place. So if you've got an older DKA patient, you know, and by older, I mean like 20, 30, 40, DKA patient, it's, you know, the risk isn't like super high. Like Tyler said, most of that stuff is like pediatric literature. They have really tight cerebral spaces. And so Tyler had brought out previously that you always run concurrent dextrose with those pediatric transfers for DKA.
Yeah, that's super important.
Transfers. And the reason you can do that is because if you're, you know, people will think, oh, that sounds so stupid. You know, you're going to run glucose and insulin at the same time, or dextrose and glucose at the same time. But it's like, as long as you're administering insulin, you're stopping fatty acid metabolism, which is their problem, or fatty acid oxidation. And so that stopping the process of creating those ketones, which is what is taking up their anion gap, which is what's putting them into the acidosis, which is what's making them breathe hard, which is what's making them, you know, making them pee. It's like there's all these things that are interconnected. So if you can just continue to run insulin, even if you ran a decent dose of like maybe D5 or something at the same time, like let's say you get to the receiving hospital and the glucose is barely changed from where you started, nobody cares. Anybody who understands DKA, they don't care. Now, HHS, maybe it's a little different. I mean, those patients, type 2, they have tons of insulin floating around. The difference is that it's just not enough to handle the glucose that they have right now. So they won't go into fatty acid oxidation, which is why they don't have ketones, because they have all this insulin floating around. There's too much insulin that just doesn't allow fatty acid oxidation to occur. As opposite processes. One is anabolic, one is catabolic. And so with those patients, you know, maybe if you're super nervous about it and you're like, what if I crash this glucose? Run it at half, you know, and then support the other findings and definitely, like, you know, figure out what your maintenance fluids are and stuff, because those patients are, you know, sometimes, and not sometimes, typically the rule is that hyperosmolar, they're usually more dehydrated than the DKA patient is.
You know what else is interesting is I've had a couple like really, really young DKA patients. And what we'll do sometimes is we'll call the pediatric doc that we're transferring them to and just consult with them. And I found on a few cases, they want you to start off just completely fluid resuscitating them because they're so dehydrated, and the sugar appears very concentrated because of how dehydrated they are. And they will be like, don't even worry about the insulin. Just give them this, 20 cc's per kilo, fluid resuscitate them, then see where their glucose is, and then we'll decide how we're going to do the insulin after that. So I thought that was interesting because you're like, oh man, we got to get this insulin in, but sometimes you just need to volume resuscitate them and find out where that puts your glucose, and then start watching how fast you're dropping it with insulin.
Yeah.
The other thing that's interesting is I was reading about calcium channel blocker overdoses causing hyperglycemia, and I don't think you talked about that in your blog at all, but you do a talk on calcium channel blocker overdoses, and the mechanism of how that happens is really interesting because calcium makes things, I think, like in the body, it makes things constrict, it makes things work, and so those beta islet cells can't secrete insulin into the body if you have a calcium channel blocker on board. So if you have a calcium channel blocker overdose that's presenting with, elevated blood sugars, that's why. And that's kind of a cool differentiation you can make as well. And you give them insulin either way. So
yeah. Going back to what you were saying about the pediatric docs talking about giving fluid resuscitation before the insulin, I think that's really smart too, because with insulin, we always think about solvent drag. And so if glucose, let's say you give insulin, and everybody knows the analogy, it's like a key that opens the door and then all of a sudden glucose can go in through it. That glucose is going to drag water with it because it's a pretty big molecule. And so that drags, and just like when we pee out glucose urea, I mean, it's dragging a bunch of stuff with it. So the same kind of process happens when insulin lets glucose into a cell too, is where glucose goes into the cell, it drags water with it. And so that can actually cause cardiovascular compromise as well. Let's say they're like super dehydrated, and then you give them some insulin without fluid resuscitating them. Like you said, that glucose might be a little altered because, it's going to be concentrated because very low intravascular volume. And secondly, if they have really low intravascular volume and then you put that into some cells all over the place, that leaves even less for the intravascular volume. So I think that volume resuscitation, especially around insulin and that patient that seems super dry, I think that's really smart. Yeah.
The other thing that, I'm not going to that's more of a hypoglycemic thing. And I think we could probably do a whole podcast on whether you should be checking a blood glucose in cardiac arrest and whether that has any role of pushing dextrose in that. But we'll get into that in another episode. We're 37 minutes into this sucker.
All right. It's time to wrap this thing up. So don't forget about the webinar that Tyler's doing, link in the description. Don't forget about the giveaway for this cool scram bag Tactical RX. It even says tactical in the name. You definitely want it.
So it's cool.
Yeah. And actually legit, like I'm not playing around, like these things are actually really cool. Tyler and I both have one that we'll be doing some sims with and stuff. Very cool. So yeah, go check out the blog. This is the last one of the Outer Limits series, man, and I'm really glad. I super enjoyed these, but I'm ready to move on to something else.
Yeah, no, it's been a great series, one we'll reference for a while, and I thought that was a great post. We got Monday, so October 4th, we got the 2021 Foam Frat update, and we got 4 big announcements for you guys, so make sure you tune in 11 o'clock Central Time. It's going to be on Facebook and YouTube. We'll put a link to that in the show notes as well.
See you guys then.
All right, let's get out of here.